I guess I'm audible. The screen is visible. Can I have, one of you can unmute now and you can just say whether.
Sir, yeah, the audio and the visuals are fine, sir. You can proceed.
Okay, fine. Yes, so now, today, good evening all of you. See, now we are going to discuss about one of the ultimate angels in restorative dentistry, that is the post and core. Whenever we think of restoring an endodontically treated, badly mutilated, the first thing that comes to our mind as clinicians is about doing a post and core. And let me tell you one thing. I'm not a very great fan of the so-called post and core techniques. I might do a post and core if at all whenever I am not sure about the bonding protocols to the substrate, that is to the available enamel and dentin. In such cases, I might do a post and core. So now let's start with the topic. Yes, we call the post and core as the ultimate angels in restoring a tooth, but most often what happens is the next day we would see, or next day maybe after a few months or maybe after some years, we would see the patient coming to you with the angel in their hands, as you see in this screen. Let me ask you one thing. It is like, do you have another tab which is opening in the middle of the screen?
No, sir.
No, right. It's just to me. Just see whether I can get rid of it. Yeah, fine. Yeah. So we would think that the post and core is some ultimate angel, and we would spend so much amount of time doing a post space preparation. Then we would go ahead with, if it is a cast post, you would go ahead with making the impression of the post space. Then you would get the casted post, or if at all you are going for a prefabricated post, you would be doing all protocols dealing with the bonding of the post into the root canal space. You would do a core buildup, you would do a crown, all these things you would do. And most of the time, the problem is there can be a high failure rate. You will see people coming to you with the post and the crown in their hand. So this is most often faced by many of the practicing dentists. Fine. Now let us find out why did all these things happen and how can we avoid all these failures in our routine practice. Fine. Now you can see a case wherein there is something like a root stump in relation to the canine region. And let me ask you, what all would be the restorative options? I guess 90% of you all would say that it's better to extract the tooth and go ahead with an implant. But what if you go to save this? So we would be discussing similar cases wherein we are going to discuss about both management of badly mutilated teeth, the newer concepts. Let me stress that once again. The newer concepts in the post and core techniques, so as to do a restoration, which is going to be lasting for a longer time. The longevity of the restoration would be more. The restoration would be in service in the patient's mouth, well in function for years together. So what are the things which we need to consider now in managing a badly mutilated, endodontically treated tooth with a post and core? And that too As I said earlier, you are hearing this topic from someone who is not a big fan of the post and core concept. Yeah, there are some cases wherein we need to do the post and core. So let me tell you, the topic itself is too huge. I'm not going to go into the history. I'm not going to discuss about various caste posts or all those things. Let me confine the talk to FRC posts, that is the fiber reinforced composite posts, and individually formable glass fiber posts. These are the two things which we would be discussing today. So when this is the situation in front of you, you can form your treatment plan in your mind. What are the different things which you would be considering in restoring this, if at all you have to, in restoring this situation. So if at all, if I ask what are the different techniques to restore such a badly mutilated tooth, you would say that take an IOP of such situation, evaluate the root length, do a crown lengthening, then do a post and core, and then do a crown, right? Fine. Yeah, these are the three things which we are going to do in case we have to restore the situation. But there is a deviation from the basic concepts which we have seen during our undergraduate or postgraduate teaching. So that is what I would be discussing today. See, I told you, I am not a big fan of the post and core concept, but I am a big fan of adhesive dentistry, which is going to be one of the most evolving forms of dentistry in the years to come. I would say that 5 years from now, most of us would be more and more focusing into the concept of adhesive dentistry, which we may feel, most of you may feel, will not work. So this case, what you're seeing on your screen, this case was a game changer to me. So here, I did a root canal treatment. Fine. And as it happens always, the pain is gone, the patient vanishes. So similarly, it happened, the patient went up. Then he happened to me one fine day in my operatory. He happened to be there. He said that for the root canal treatment you have done, I have a pain on that tooth. Fine. Let me check. I took an IUP and I could see all characteristics of a classic vertical fracture. You can see it in your slide, in your screen. And then I extracted that. You can see the second picture. It's a classical vertical fracture. The tooth was split into two. Fine. And what I did is, I stuck this, re-implanted the tooth. Fine. This person was my next shop guy. And I thought, let me give a try. Let me see what is going to happen in this case. So I re-implanted it. Followed it up for 2 years. And after 2 years, I took this as an abatement and gave a bridge. And you can see the last IOPA wherein you would see that the bone is well regenerated, the bridge is well in service, and for the last 12 years, this is staying in service. I still don't know what has worked here. To be very frank, let me stress upon my statement. I still don't know what has happened here. Fine. So this was a turning point in my practice wherein I started focusing more and more into adhesive dentistry. Fine. So even though with the topic being about post and code, let me tell you one thing. My preferred technique would be to go ahead with adhesive dentistry. I would be doing a post and code only if I don't have the substrate, I don't have the tooth material, I don't have good enamel and good ending left behind to do adhesive dentistry. In such cases, I may think of going ahead with a post and code. So this is the newer concept. I would just rush through this case. By all means, this is a badly mutilated tooth, a young patient, wherein you would see that even the second molar is not erupted. The biggest problem here I would face is I would not be able to isolate this tooth by rubber dam isolation, which again, let me stress upon. For all modern dentistry, there are two things which are very necessary. One is rubber dam isolation. Second thing is magnification. Without rubber dam isolation and without magnification in some forms, modern dentistry is not very possible. I'm very clear about that. You need to, if at all you all have not invested into some form of magnification, please to invest. If you all have not started with rubber dam isolation, please to start. Fine. So here my biggest problem being, I will not be able to isolate the situation very well with rubber dam. So I went ahead, removed all the soft tissue, created a soft tissue convenience form. All the interfering soft tissue was removed, went ahead with rubber dam isolation, the root canal treatment was completed, and waited for about 5 weeks. Now you would see that the soft tissue is very well healed. I can go ahead with a definitive restoration. Again, rubber dam isolation, a composite buildup, a preparation for a direct bonded porcelain overlay, and a bonded porcelain overlay was bonded into the tooth. And this is the final result. So here, if you see, though the tooth was badly mutilated, though the tooth was endodontically treated, we never went in for a post or a crown. Rather, we went ahead with a much more minimally invasive technique. So we never had a post, we never had a crown, and yet we were able to deliver a very good result to this. So that is what modern dentistry, or this is the concept where modern dentistry is heading on to. Fine. So we would be doing a post and code wherein we are not having enough dentin as well as enamel for bonding. Earlier, we used to say that dentin bonding is too vulnerable and enamel bonding is something which is we are all going to wait for, which wherein all the result is going to come from. But no, nowadays dentin bonding is also equally good, or in fact, it is much better than enamel bonding. So whenever you don't have good dentin and enamel for bonding your restoration, you would be thinking of a post and code. So that is something which I need to straight away establish. We would think of a post and code only if we don't have adequately bondable dentin and enamel. Fine. So that is the comparison between the pre-op and the post-op of that particular case, which we were seeing now. Now we have to think where all we went wrong with the conventional post and core concepts. We went wrong in doing a very invasive root canal treatment, wherein we flayed the root canals too much to get a very good radiographically good appearance that your root canal treatment is looking too great. That's something wherein we are going against the concept. Then what did we do? We prepared a very beautiful pause space, which was too huge. We took an impression of that. We casted the post and core. We luted that, and then we gave a crown. Technically speaking, everything went very well. But the end result is as we saw in that second stage, second slide in the beginning. After some time, you have the patient coming with all these things in your hand. Fine. That was the thing which was happening with the conventional post and core techniques. Now, we have to think about certain factors and think literally too keen about certain factors, which is going to enhance the longevity of the tooth. So let's have a look at that. That is how to improve the biomechanics of a post and core. So when coming to managing an endodontically treated, badly mutilated tooth, the most underrated thing is, or the most underrated problem is, we never considered the pericervical dentin. Now, what is the pericervical dentin? The dentin, which is 4 millimeter above the alveolar crest and 4 millimeter below the alveolar crest. This zone is very crucial because this is the area which has maximum significance in transferring the occlusal load from the occlusal table to the roots of the teeth. And we have to understand that this pericervical dentin is something which is irreplaceable. No matter whatever be your filling material, whatever biomimetic you become, or whatever biomimetic concepts you put in, if you intrude into the pericervical dentin, you are creating a structural damage to the tooth. That is for certain. Fine. So what we have to do? Inflict minimal damage. See, whatever said, you would be encroaching into the pericervical dentin. So now you have to focus on minimizing the damage that you inflict to the pericervical dentin if you want the tooth to stay inside the patient's mouth in service for a longer time. Fine. So here is a case. I've done a very fabulous root canal treatment. You can see the mesiobuccal, the mesiolingual, the isthmus between the mesiobuccal and mesiolingual. It's all filled. You would see the multiple distal canals. You can see 2 distal canals. When you come to the apical portion, you can see the anastomosis between all these things. That is the 2 distal canals. You would see the multiple portals of exit. Everything. Fabulously done root canal treatment. But if you don't plan the restorative phase, well, this tooth is never going to stay for long. All the effort that you have done in the root canal treatment is going to go waste. So you would see the soffit is preserved. Earlier we used to speak about straight line access. No longer we speak about that. We need to preserve the soffit. That is the roof. Fine. In simple words, I can say that the roof of your pulp chamber, which earlier we used to de-roof and we used to render a straight line access. Now we say that you should not be doing that. Fine. So the soffit is preserved. You would see that the isthmus between both the mesial canals, the mesiobuccal and the mesiolingual, all those are nicely filled. And then you would see the distal anastomosis, isthmus filled, fabulous root canal treatment together. But what has happened? There is a terrible loss of the pericervical dentin when you have done this. So by doing a root canal treatment, you have actually infringed into the pericervical dentin and you have created a structural damage to the tooth in the perspective of the longevity. Fine. So it's a compromised tooth. You have to accept. Now, what if you are doing a crown preparation here? Again, you are removing the pericervical dentin. So the most crucial zone, that is the pericervical zone is terribly interfered, and the longevity of the tooth is a bit question mark. And on top of that, imagine you go ahead with a post. On the distal side, you would see that you are almost on the post. So the structural rigidity, the structural element of the tooth, which is going to enable the tooth to have a greater longevity, is totally lost. Biomechanically, this is a structurally too weak tooth. And then you give a crown, and after some time, after some months, after a few months, or after some years, you have the very same patient coming to you with an en masse fracture of the post, crown, everything. Fine. So in this presentation, I am going to deal with those techniques which would enable you to do a post and core, wherein you preserve the tooth structure maximum, wherein you don't encroach into the pericervical dentin to a great limit. So that is what we are going to focus. And for that, we would be mostly focusing our discussion into FRC post, so-called fiber post. Fiber posts are fiber reinforced composite post. Fiber matlab, it is glass fiber reinforced composite post. And another one type of post which we are going to discuss today is the individually formable glass fiber posts. These are the two things which we are going to discuss. Fine. Cast post, I'm not discussing now because cast post, what do we glorify the cast post as? We would say that cast post is that type of a post wherein we customize the post according to the canal space. But that is something which is a wrong state. Fine. You prepare a post space, right? When you prepare a post space, you have your piezo reamers or Gates Glidden drills going into the canal. When you have a Gates Glidden or piezo reamer going into the canal to prepare the post space, ideally the canal take the shape of the piezo reamer or the Gates Glidden. Fine. So your cast post is going to replicate the shape which has been created by the piezo reamer or Gates Glidden. So hence, there is no point in calling them customized posts. They are actually taking the shape of your instrument which has gone into preparing the post space. Fine. Now we are going to discuss about those posts wherein you don't prepare a post space. Fine. The difference is earlier we were too specific about preparing a post space. Now we are going to discuss about those post and core techniques wherein there is no preparation of post space. Now, as dentists, one of the biggest problems we face in dentistry is the one that is about over-engineering. Fine. Now, what is over-engineering? In a simple slide, I would explain. Let me tell you to catch your right ear or left ear. It's so simple. But in dentistry, we don't do it in that way. Or we are not taught to do it in that way. We are always taught to think about the difficult path. Fine. So that is over engineering. And I don't think I need more words than this slide to explain what do I mean. Okay. Now coming on to the pericervical dentin, again, let me stress upon this slide. You have seen this earlier. We have stressed on the importance of saving the pericervical dentin, right? Now, when you do a post and core, One sec. Excuse me. Yeah. So when we do a post and core to restore a battle nucleated, endodontically treated tooth, there are three things which we need to consider. That is, we have to be very minimally invasive with the root canal treatment. Then you have to be very minimally invasive with the post placement. And then you have to be equally minimally invasive with the crown preparation. So these are the three golden rules in doing a successful post and core. Fine. So here is where there is a paradigm shift. This is where we need to deviate from what we have learned in our UG or PG curriculum. Fine. This is where you have to incorporate the newer concepts of biomechanics into your practice, wherein you can give a longer lasting outcome to your patients. Clear? Now coming on to the case which we saw in the beginning. The same case of a canine root stump. Nothing more than a root stump, right? Yeah, that's the palatal view. I mean, that is the occlusal view wherein you can see the palatal aspect also. So this is something which the big people call the deep margin acquisition. Fine. Wherein you don't do anything. You create a soft tissue convenience form. So what do you mean by a soft tissue convenience form? You remove all the soft tissue so as to gain an access into the deepest portion of the margin of the tooth. And it is very clear from this picture that all the margins of the of this tooth is well acquired, and this was done here. This was done with an electrocautery. Once that is done, nice Teflon packing was done circumferentially, and then a rubber dam isolation, and this was followed by air abrasion, sandblasting the entire enamel and dentin so as to remove all the biofilms and get a very good conductive surface to bonding. Once that is done, a pre-endo buildup is done. And as I said, rubber dam isolation is too mandatory. There is no restorative dentistry or endodontics without proper rubber dam isolation. All restorative dentistry and endodontics without rubber dam isolation is nothing but quackery. Let me be very blunt with this. But let me be very clear with the statement. If at all you want to do very good endodontics and very good restorative dentistry, rubber dam isolation is mandatory. Fine. So a pre-endo buildup is done, which was followed by the root canal treatment. And then an individually formable glass fiber post. And this is something which you would be thinking, what is this? Yes, I am coming on to this. So this is actually very thin glass fibers interspersed in a resin. That is, you have a resin matrix which has lots of vertically oriented glass fibers into that, which is flexible also. When you light cure it, it becomes hard. And since there is multiple glass fibers, you can twirl it, you can make it broad, wherein you can turn clockwise and you can compress them. You can take a scissors, you can cut wherever it is going to hit in the pore space. That is, you are not preparing a pore space, rather you remove the GP from 5 to 6 millimeters from the orifice level. And then you are going to customize this post according to the anatomy of the canal. So this is truly something called as a biomimetic post, or rather this is the actual customized post. Fine. So I have not removed so much of pericervical dentin here. So that is an individually formable glass fiber post placed into the pore space. Post, not the pore space, the space created by removing the cataparka. It's another view, followed by a core buildup. That's the excess, all the excess composite was removed, or the core buildup material was removed. That is what we see at the end of the treatment. You would see the soft tissue toughened circumferentially. You would see a good ferrule. That is, you have adequate 2 to 3 millimeter of circumferential tooth surface so as to create a ferrule effect on your final prosthesis. And then a temporary crown is given, and you have to wait. You have to wait for 5 to 8 weeks. You have to give time for the gingiva, for the soft tissue to mature, for the sulcus to be re-established, to the papilla to be redeveloped. So that is, after 5 weeks, you would see that the soft tissue is nicely matured, and the bleeding, what you see, is because of sandblasting. So before luting the final crown, again, you have to sandblast the surface, get rid of the biofilms which is on the surface of the tooth, and then only you can lute a crown perfectly to your prepared tooth. Fine. So air abrasion is something which is not a luxury. It is something which is 100% needed. And the final crown is luted, and you have to literally butcher the gingiva circumferentially and make sure there is no cement remnant present anywhere. And then you have to expose an IUPA to clarify the same. And that's the response of the soft tissue. After 48 hours, you would see nicely the soft tissue is responding. And the fact is, if you have a nicely polished prosthesis surface, your soft tissue would gain an attachment to that. By polished, I don't mean it is glazed. You are not supposed to glaze the subgingival portion of the prosthesis. Rather, you are supposed to polish that. So this is the actual protocol for rebuilding a tooth from a root stem to something which is 100% functional. Fine. Now let's see the steps in doing an individually formable glass fiber post. So this is the individually formable glass fiber post. It would take the shape of the root canal. So you would cut sufficient millimeter. Then you would mark the length, whatever is needed by you. Once you take it out of the pack, keep it away from some light, from the light, so that it doesn't set. Then clear the canals, clear the GP, everything. Introduce your bonding agents and cement into your root canal space. And then take the fiber inside, remove the excess cement. You may turn it anti-clockwise to spread it out, light cure it, build up the core. So here, the individual fibers are going to take the space of the root canal. You don't have to prepare the root canal space. Instead, you just take out the GP from the coronal aspect. Fine, that is all about individually formable glass fiber posts, wherein the advantage is your infringement into the pericervical dentin is the least. Now let's come across a case. Excuse me one sec. Yeah. I'm sure you all understood which is the restored tooth, right? So you would see a fracture of this, the central incisor. The fracture looks very favorable from the facial aspect or from the buccal aspect. But you can see the slide from the lingual aspect, it is way too subgingival. Fine. So here, it's like I cannot say. I mean, I'm not able to say that this treatment would give a very good prognosis according to the literature we follow, but we'll see what will happen. So since the palatal margin was V2 subgingival, we opened the flap, trimmed the bone, acquired the deep margin. You would see the rubber isolation. And then we did a root canal treatment, reattached the coronal fragment with a glass fiber post for coronaradicular stabilization. See, one thing, let me be very specific to you. A post is never going to strengthen a tooth. It is just going to stabilize the coronal as well as the radicular segments. So post is something which is going to stabilize the coronaradicular segment. It is never going to strengthen any tooth. For that matter, no restoration, how much ever adhesively it is done, is never going to strengthen a tooth. If a tooth has to last for long, the tooth has to be strong on itself. That is the fact. You will never render a tooth strong by any magic restoration. Let me be very specific about that. So here, the segment was reattached. I was not sure about the prognosis of this case. And here, that's a 1 month follow-up. I could see the palatal tissues was responding fabulously. And this is after 1.5 years. And this is almost after 3.5 years. See here, you would see that if you follow the margin of where to what extent the composite is gone, it is almost gone to the coronal third. Still, there is no attachment loss. Still, there is no bond loss, which happens as due to the irritating restorative material, nothing. All the bond levels, everything is well maintained, even though I did a wrong thing with this case. That is, while doing the root canal treatment, it so happened that there was a bit of overextension, but somehow that was very well tolerated by the nature. And here you would say that in this case, I didn't go ahead with a crown or I didn't go ahead with a core buildup. It is just a post, just a fiber reinforced composite post done over here so as to stabilize the coronal and radicular fragments. Exactly fragments as you see in this case. Fine. So it is not mandatory that you have to always go for a core buildup as well as a crown. Sometimes you can manage your cases in this way too. And the most important thing is adhesion in dentistry is much more evolving than what we used to consider about it. If at all we get a good adhesion, we can always give good long-lasting result to our patients also. So start focusing more on adhesive dentistry. The advantage being you would be more and more patient-centric. Fine. I would say that this is a very patient-centric treatment because for a badly mutilated tooth, almost for it is more than 5 years since I have done this. I don't have a follow-up. I don't have the latest follow-up. But for a tooth which was having a very hopeless prognosis, we could at least extend the life to more than 5 years with that. So focus on your adhesive protocols. You are going to get very good results. Yet another case of a root stub. As I said, it is just a root stub, nothing more than that. Again, rubber dam isolation. Post-paste preparation, you can see I've used the piezo reamer, size 3. Piezo reamer was used to prepare the post-paste. Now, how would you bond the post? I want all your attention to this concept. How are you going to bond a post to the dentin? The first thing, when you want to bond a fiber reinforced composite post, the first thing to do is sandblast the post. When you sandblast, you erode away a bit of composite from the surface and then you expose the glass. It is not that you are just exposing the glass, but sandblasting is going to render the glass particles, the glass fibers in the post also rough. So once you have done that, you would apply a saline coupling agent. Once you apply saline coupling agent, keep the post for a minute. Fine. Now you come to the tooth. You have prepared a post base. And then the last picture, what you see over here on the right hand end, you would see something by the name Paracord, and you would see 3 bottles. You would see a green bottle, you would see a red bottle, you would see a yellow bottle. I guess all of you are following. The first one, the green bottle, is a dentin conditioner. You are going to apply the dentin conditioner into the pore space. Fine, it's a non-rinse conditioner. You don't have to, again, rinse it off. Just apply the non-rinse conditioner on the dentin, on the pore space. Fine. Then mix the red and yellow bottle. Take one drop and mix it. So this is going to activate your bonding agent, and it is going to convert your bonding agent into a dual cure or into a dark cured bonding agent. That is, your bonding agent is going to get cured even if you are not photopolymerizing it. Fine. Because when we deal with a post-encode, the biggest problem is we are not sure of what is going to happen at the depth of the pore space. Will the composite you apply on the depth of the pore space is going to get cured? That's a big question mark. By using a bonding agent which is capable of dark cure, you would override this problem, this issue. That is, your bonding agent is going to be cured on its own, even if you are not photopolymerizing it, even if you are not light curing. So apply it into the pore space. That is, you take 1 drop of red bottle, take 1 drop from the yellow bottle, mix them, and you apply it inside the pore space. You apply the same onto the post also. Then you inject the Paracord, that is the dual cure cement. This can be a cement, this can be a core buildup material, all these things. So Paracord is something which is very versatile. It can function as a cement, it can function as a dual core buildup material. So I am going to inject the Paracord, that is the double barrel syringe, what you're seeing in the picture. So I would be injecting into the pore space. Slowly I would seed the post, and then I would complete with the core buildup as you see in this slide. And once you complete the core buildup, photopolymerize, light cure from the buccal and lingual side. The external surface would be hard. Then you cut off the excess post. Go ahead with the crown preparation. That's an occlusal view. That's after the crown preparation. I've done a gingivectomy here. And now you would see that I have established enough and more tooth material coronal to the gingival aspect, so that my crown is going to have a very good ferrule effect. So once that is done, I would give a temporary crown and wait for 5 to 8 weeks till the gingiva heals and papilla is getting re-established. And once that is all done, I would remove the temporary, sandblast the tooth, get them devoid of all the biofilms, and then I would go ahead with luting the crown. And these are another type of crown preparation, which is called the vertical crown preparation. In a vertical crown preparation, the diameter of the tooth is never altered. The diameter of the root of the tooth is never altered. You are not creating a finished line. It's altogether a different concept. We should be having a different episode to discuss about that. It is beyond the confineness of this talk to discuss about a vertical crown preparation also. But understand it's a crown preparation wherein there is no infringement into the pericervical dentin. You are not going to remove the pericervical dentin, or rather the diameter of the tooth at the cervical area remains the same when you do a vertical preparation, which has special burrs also to do the same. So similarly, a preparation was done and a prosthesis was luted. And you would see the IOPA also. As a pre-op and the post-op. So I've shown you here how to go ahead with restoring a root stump, which can be in function for a long time. And this would be a well-engineered, biomechanically viable restorative technique. Now coming on to another case. A case wherein the crown was lost. The tooth was earlier root canal treated. Now, when I took the IUP, there was a disaster. There is a lot of root resorption. The old endo was not very sufficient. It was too inadequate. So it is very clear that I have to do a retreatment here. So before starting with the retreatment, it's imperative that you have to go ahead with rubber dam isolation. No other, no root canal treatment, no restorative dentistry without rubber dam isolation. Fine. So here is a split dam. And then I have to do a pre-endodontic buildup. That is, when I do a root canal treatment, I want all my irrigants to stay within the tooth. For that, 4 volts of the tooth are very important. So I would just matrize the tooth and then go ahead with a composite buildup. Once the composite buildup is done, I would change the split dam. I would do a proper rubber dam isolation and then go ahead with the root canal treatment, removing the GP, establishing the working length, taking the master cone X-ray, completing my obturation. The obturation was done. And then an individually formable glass fiber post. Now you could see that the post is going to take the shape of the canal. I am not going to prepare a post piece. I would just remove GP from 5 millimeter into the canal from the orifice level. And then a cord buildup is done. A vertical crown preparation is done. You would see that the diameter of the tooth is not changed at all. I have not infringed into the pericervical dentin at all. And then finally an impression is taken and a prosthesis is given. And you would see the excellent soft tissue response. So don't think this prosthesis is going to interfere into the biologic width or something like that. No, you have to understand this as a different technique. It has different ways and means to attain good soft tissue response. All these things are all together. Vertical preparations, vertical crowns, luting them, managing them, impressions, all those things are totally a different entity, and I'm not going to discuss that today. So you would see the soft tissue response here. You would see good band of thick keratinized gingiva surrounding the prosthesis. And that is how we restore a badly mutilated tooth. Now coming on to yet another case wherein you would see that it's a badly mutilated mandibular anterior tooth. In such a situation, giving a crown would be a blunder. I would not say it's a disaster. It would be a blunder. Fine, because you would remove all the pericervical dentin, whatsoever vertical technique you do, you would still encroach into the pericervical dentin and you may not be able to rescue the tooth. You may not be able to salvage the tooth. So in such a situation, I would go ahead with a root canal treatment, very, very, very conservative. Very thin preparations. I didn't go to the ProTaper preparation or anything like that. It's a very thin preparation. And you would see that there, see, all mandibular anteriors, most of the time, they would be having 2 canals. Fine. So you would see a decent enough obturation. And then for the restoration, again, we have to have a rubber dam. The missing wall is being managed by bioclear matrix, an individually formable post, followed by injection molding with composite. And that's the final result. And you would see how well the composite is adapting to the cervical area. And you would see 2 individually formable glass fiber posts in both the root canals. I have not done any post-based preparation. It is just that we just removed a bit of GP from the coronal aspects of the canal. So that is how we should be going ahead, or this is how we should be going ahead when we are restoring a badly mutilated tooth. Yet another very beautiful case. A post and core was done, and This is one of my dentist friend, wherein he had got this root canal treatment and post and go done. Then it was like there was a periapical change. We had to, he was asking me what to do, how to do a retreatment. I said the prognosis is going to be very poor and somehow deferred the treatment to a later date. But finally, one day he came to me with a dislodged crown. And you would see that it's a hopeless structure, right? It's a hopeless structure. I would agree to that. It's a hopeless structure. Prognosis of this treatment is going to be very bad. But somehow, that's a size 3 retraction cord in place so as to retract all the soft tissue, acquire all the deep margins of the tooth. I just went ahead with a core buildup, or rather a pre-endodontic buildup. Root canal treatment was completed, post was placed, core buildup, everything was completed. Now I don't have to explain about each and every step of post placement, but because I've done that, a temporary crown was given. And when the temporary crown is removed, you would see that well-healed gingiva circumferentially. You would see very good structure. Now I am going to get more than 3 millimeters of sound tooth structure circumferentially, which would give a very good ferrule effect to my crown. The crown, final crown is luted. And this is after the soft tissue healing. And you would see the gingival response is simply awesome. And you can see the post-operative radiograph 2. So that is how we restore a badly mutilated tooth after endodontics to proper function. One more case. This tooth was fractured. We opened the flap, trimmed the bone to acquire the deep margin. And then that is the isolation, a pre-endo buildup. Then retreatment was done, followed by placing individually formable glass fiber post in all the 4 canals. That too with no post space preparation. Let me tell you one thing. If you are going to prepare a post space for a mandibular molar, the post space should be prepared only in the distal root. For a mandibular molar, you are supposed to prepare the post space only in the distal root. If it's a maxillary molar, you should prepare the post space only in the palatal root. For your premolars, you can use either the buccal or the lingual canal. For anteriors, you don't have any other option, but there is only one canal. You can use that for a post and core. But here, since we are not preparing a post space, we are just removing the coronal GP. We can place an individually formable glass fiber post in all the canals. A core buildup was done and a temporary crown was given so as to allow the gingiva to heal properly. And after 5 weeks, you would see well-formed gingiva, excellent soft tissue response on the buccal side. The papilla is reformed. On the lingual side, again, you would see well-healed gingiva. And that's the final crown preparation. You would see the sulcus is nicely established. And before luting any crown, apply a disclosing agent, see for the biofilms, remove the biofilms, and then go for luting your crowns. The final crown was luted, all the excess cement was removed, and you would see excellent soft tissue response after a week. So that is how we restore a badly mutilated tooth with a post and core. Coming on to another case wherein there was a huge class-wide defect, which was almost approximating the root canal space. Obturation was done, and you would see that very cervically there is little tooth material left. And I don't have the option of giving a crown here, or rather I don't consider at all giving a crown in such cases. So root canal treatment was done with a buccal axis. A post and core was done in the very same buccal axis. Occlusally, it was not opened at all. And you would see that the post is somehow jammed into the root canal space. You would see the coronal extent being tightly fitted into the canal space. Somehow I managed to get the things done. And you would see there is a total butchering of the buccal surface so as to do a composite restoration. Somehow, after a week, I had a very good response, and just not the level of composite and level of gingival attachment. And somehow I lost the recall of this case. And I was seeing this case after 5 years. Now you would see that well developed, thick keratinized biotype, which has actually creeped up. Fine. In the 10 days follow-up, you would see the gingiva is confined to a much more apical level. And after 5 years, you would see that it has creeped up and there is good soft tissue health and no crown given, just stabilizing the coronaradicular segment with a fiber post. And with this, we are coming on to the last case of today's discussion, wherein it's a totally different technique. And this is just a fresh catch. I have done this case just today. We finished this today afternoon. So here is a case wherein a root canal treatment was done and a cast post and a crown was given, and the patient is not so happy with the aesthetics. So he wanted to redo the entire thing to get a most aesthetic outcome. And you all know it's a nightmare to remove a cast post. Somehow I got it removed. And why did I keep this photo? See, when doing any post and core, before rubber dam isolation, it is very, very important for you to pack a retraction cord. And here, if you see, it's a size 3 retraction cord, which is packed into so as to nicely retract the gingiva away. Then I would go ahead with the rubber dam isolation. You can see the rubber dam isolation. There was no much need, but I went ahead repeating the root canal treatment. A non-surgical retreatment was done. The old GP, everything was removed, canal was nicely irrigated, and it was reobturated. And you would see on the right side, left side, you would see a picture, a microscope view of the clear post space. I didn't prepare a post space. It was already prepared years back. Fine. And you would see the apical segment of GP here. Then sandblasting the glass fiber post. So what is next? You sandblast the post, wash it off properly, air dry it, apply silane coupling agent, keep it for a minute. Then you have to apply dry air. And then on the post space, first you apply a conditioner, then you apply a mixed drop from the red and yellow bottle. You mix it up, you apply inside, that is the adhesive inside the post space. You apply the same adhesive onto the post also. Apply the dual cure cement, something like a paracord, into the root canal space, into the post space. Place the post together. The same cement can be used for the core buildup also. So here you would see that was an enormous post space. So what I have done is, I have placed an individually formable glass fiber post along with a fiber reinforced composite post. I would have placed 2 or 3 individually formable glass fiber posts, but it is like these posts are very expensive. So what I did is, major space of the canal was filled with the fiber reinforced composite post. Whatever was the residual space surrounding that is filled with the individually formable glass fiber post. You would see both the ends, that is the individually formable glass fiber as well as the glass post, along with the core buildup here. This picture makes it clear. You can see the FRC post as well as the individually formable glass fiber post on the IUPA given on the corner, top corner. And that's the comparison between the pre-op and the post-op. And let me once again, let me make it very clear. Even for the post-op preparation, your gingival retraction cord is very, very important. And not only that, but even before your final crown impression, you have to retract the gingiva, you have to nicely place a gingival retraction chord, and then make the final impression. So with that, let me wind up. And in all my presentations, I do make it a point to acknowledge my crew. So you can see on the slide, this is my crew. So see, something which we have to really understand is dentistry is a teamwork. Each and every member of the team is very, very, very important. So this is my team. This is Team Outlook. And all the cases which we do is a combined effect of all the members of our team. Thank you all. So with this, let me conclude my presentation. Thank you all for the patient hearing. Now, let's discuss about the questions.
Okay, sir. I think we have few questions here. So I'll read out one by one so that you can answer all of them. Okay, sir. Yep. So there's one question. How many millimeter of GP from orifice should be removed for ever exposed?
See, according to the modern concept, you don't have to prepare a very deep post space. Earlier, we used to say that the apical 5 millimeter of GP should be kept untouched and rest of the space should be used for the post. So that is not valid now. We just need 5 to 6 millimeter from the orifice level, nothing more than that.
Okay, sir.
And that is when you're considering about a bonded post.
Okay, sir.
Yeah.
So the next question is, can we use the universal bonding agent instead of paracore bonding agent?
See, I have made it very clear why we are using a paracore bonding system. I'm not a big fan of, I'm not a speaker of Coltin or anything like that, but I'm using a dual cure bonding system because I'm not sure whether my universal bonding agent is going to get cured at 5 mm depth. That is from the 5 mm is from the orifice level. You have the coronal structure on top of that. So we are not sure about getting the bonding agent cured at that depth. So it is always better to think of some material which is capable of dark cure. I've made it clear during the presentation also. Yeah.
So the next question is, would you recommend any textbook for adhesive dentistry?
There are many, enough and more textbooks about that. Let us have a different discussion altogether to discuss about the textbooks.
Okay, sir. So how to remove the coronal portion of the GP for glass fiber post?
Yes, it's a good question. You can remove it with a heat source, something like a touch and heat, wherein the tip of the instrument gets heated to 200 degrees centigrade in no time, and that can be used to remove the GP. If you don't have all these things, you can just cut off the water from your scaler tip, the interdental scaling tip, and you can just pocket into your root canal from the orifice level to 5 millimeter apically. Just activate the scaler. You would see that with the vibrations, your GP gets plasticized because heat is produced because of the vibrations, and then you can remove it.
Okay, sir. So the next question is, can you explain how intraoral air abrasion is done?
See, air abrasion is something, I have to speak about this. It's like, you can classify air abrasion into microblasting as well as microetching. In microblasting, you don't cause any alteration to the hard tissues, that is to the dentin and enamel. Wherein most of the time in microblasting, the abrasive which we use is something like calcium carbonate, aluminum trihydrate, you can use sodium bicarbonate. So these are the things which we use for microblasting. In microetching, we use alumina, usually 23 micron alumina or 56 micron alumina is used for sandblasting or micro etching. So those are the things over here. And to microblast, you need a microblaster. To micro etch, you need a micro etcher. So these are the two things which you may need in your practice if you have to focus more on adhesive dentistry.
Okay, sir. So the next question is, how much crown lengthening is necessary for the post preparation?
See, our aim is to get a 3 millimeter tooth material above the gingival level. Fine. So that is the guideline. So when you do a crown lengthening, keep this in your mind, and accordingly you can trim the bone and trim the gingiva.
Okay, sir. So there's another question. Which one is better in the view of retention? Is it the FRC post or the threaded post?
See, I'm not speaking about retention here. We are speaking about adhesion here. And threaded post is something which is obsolete. We are not considering it. So when we talk about adhesion, retention never comes into picture.
Okay, sir. So instead of sandblasting, applying etchant will give the same effect?
See, there is no replacement to certain techniques. For adhesion, sandblasting is mandatory. In fact, when you etch the dentine, your post piece is all in dentine, right? It's like, nowadays all your bonding agents have 10 MD. So they establish ionic bonds with the dentine. So when you etch the dentine, all the remaining minerals in the dentine is lost. So your bonding is going to be lesser when you're thinking of etching the dentine.
Okay, sir. So the next question is, what is the ideal mesiodistal width of PCD, pericervical dentin?
Ideal mesiodistal width of PCD. Not very sure about it.
After application of saline coupling agent, do we directly apply conditioner?
Saline coupling agent is applied onto the post. You don't have to apply a conditioner to glass. Your fiber, your post is glass. You don't have to apply a coupling agent. A conditioner to your post. You just go to apply the adhesive to the post.
So how much time do we have to place a retraction code prior to impression?
At least 5 minutes.
I'm trying to search for the questions which is related to topic. There are many out of topic questions actually. Yeah. Okay, so instead of okay, this one question. Instead of Everex post, can we use Everex flow bulk fill and inject into the post piece?
See, the direction of fibers in an Everex post as well as your Everex, your bulk fill posterior is totally different. So both of them cannot be a replacement.
Is it better to do curing fiber post first and then core buildup, or all together?
Whenever you are using, as I have said, discussed now, whenever you are using a bonding agent which is capable of dual cure or dark cure, and whenever you are using a cement which is capable of dark cure, then there is no point in curing it separately, right? What I mean, in paracore, it is like if you don't photopolymerize also, it is going to, everything is going to get cured in 4 minutes time.
So what is your opinion regarding metal post?
This is not the time to discuss about something which is obsolete.
Okay. I think we had answered most of the questions, sir. Some of the questions are actually out of topic. So hopefully we'll try to make a discussion about those those topics as well, like the abrasion, the adhesive dentistry. Hopefully, even I think Shibu sir will be definitely interested to.
Like if certain things goes out of the topic, because see here the problem is when these things, post and core, adhesion, all these things, it is like there is a very thin line wherein we differentiate it into different topics. So due to the time constraints, we will not be able to discuss about everything.
Yes, sir. And if any other questions are present, we can definitely post those questions in the WhatsApp group or our social media platforms. Yeah. So that can be rectified. Yeah. Okay, sir. So thank you so much, sir, for sharing your knowledge and expertise when it comes towards performing a post and core treatment. So definitely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussion. So, yep. And if you're really interested to have a deep insight of this treatment, we do have this exercise in our endo program, which is going to be held at 18, 19, 20, which is Friday, Saturday, and Sunday of this November. So if anybody is interested, you can contact the mentioned number for this registration. So if you want to know other details about this program is...
And if anyone is interested in knowing more about the bonding protocols, you can join for a indirect workshop, which is going to be on 3, 4, 5, 6 November.
Yes, sir. Yes, sir. Definitely. So this the endo program we have, it includes intensive hands-on exercise on extracted teeth, a live case demonstration, and also everyone will get a chance to perform a single visit endo on live on patient as well. So if anyone is interested for the adhesive dentistry, we do have it on 3, 4, 5, 6, as sir said, in which direct composites, both on anterior and posterior, as well as indirect restoration, which is like onlay, overlay, veneer, laminate, etc. So that also we have a live case demonstration where when it comes towards indirects, Dr. Shibu sir will be demonstrating the preparation to cementation of an indirect restoration live on patient. So as we said, you can contact in the mentioned numbers for the registration. So thank you so much, sir. So it was actually very informative. And
thank you, Dr. Shanu, for coordinating the event, and thank you, Team Safe Dental, for the platform. And let me thank all the participants for the patient hearing. And I hope I was able to impart at least some small amount of things which I know to all of you.
Yes, sir. So thanks to all the doctors who had participated for this webinar, and we made an initiative in such a way that we'll be conducting free webinars once every week for everyone. So thank you so much. Thank you so much, sir, again. And
thank you all.
Thank you all. Thank you all, and have a great night.
Yeah. Good night. Good night.
Good night.